So good evening, and welcome to the continuous medical education talk of the Kenya Society of Hematology Oncology, which we host every Thursday on a variety of education and networking, as well as partnership topics. Now, this week we dedicate our talks to the International Women's Day, which is celebrated on 8th of March. And this year it falls on Sunday and will be celebrated around the world with the theme of rights, justice, action for all women and girls. Now, this started a long time ago and has been celebrated over the years, looking at justice and dignity for women. The International Women's Day color themes this year will be purple, green, which stands for hope, and this is a combination of quote unquote the feminist movement. And this evening, Kesho dedicates the International Women's Day to great women in science and especially oncology. And this evening, I'm privileged to host 4 women who will tell us about their great work in oncology. I'll introduce them one by one, giving a little background about what the amazing work they do. And I'll start with Professor Vanna Vanderpuye, who is a clinical oncologist in Ghana. All of us who've been in the oncology world look up to Professor Vanna, who has retired from public service now, but is affiliated to the Kolebu Teaching Hospital in Ghana. She's a past chair of the International FAT in ASCO and has been a co-editor of the editorial board and reviewer of several cancer journals, and also serves as a co-PI in the External Advisory Board in several international research training grant reviews. Now, she's actually also has won an award in 2019 for International Women Who Conquer Cancer Mentorship Award in 2019. She has over 100 peer-reviewed journals and has written several book chapters. And this evening, she's going to talk to us about legacy and leadership and mentorship from women advancing oncology in Africa. Our next great speaker will be Professor Nazik. Professor Nazik is based in Canada at the St. Michael Hospital in the Department of Medicine and in the University of Toronto. Her academic work involves a lot of work in middle income and lower income countries, especially sub-Saharan Africa. And she's published widely in medical education, including faculty development. So she collaborates widely with women in Africa and insists on choosing wisely on what initiatives Africa should get involved in. She's chair of the African Organization for Research and Cancer in the Significant Interest Group in Cancer in Conflicts and Other Humanitarian Settings. So Professor this evening is going to talk to us about leading with purpose, about lessons in global oncology, mentorship, and building impactful careers. And this is quite important for all of us women. Dr. Anne Wirigi is a consultant hematologist and assistant professor at the Aga Khan University Hospital, Nairobi. Anne is passionate about malignant hematology, good clinical governance, and is committed to high standards of patient care. She is head of the hematology session at the Aga Khan and oversees patient care governance and education. She also chairs the Hematology Tumor Board, the Mortality and Morbidity meetings, and is a founding member of the Undergraduate Medical Education Committee. Anne did her degree in Glasgow and also did her specialist registrar training at King's College Hospital and Guy's and St. Thomas in London. Welcome, Anne. So Anne this evening is going to talk to us about growing in specialized oncology, career lessons, and mentorship in hematology. The other speaker we have the privilege of having today is another great young lady called Chemutai Mungo, who is an assistant professor of obstetrics and gynecology and a physician scientist at the University of North Carolina at Chapel Hill. She did her training from the University of California, San Francisco, and holds a master's in public health from Johns Hopkins Bloomberg School of Public Health. Her research advances are in cervical cancer prevention in low and middle income countries with a focus on self-administered intravaginal therapies for HPV infection, cervical precancerous lesions as well. She is the PI of several phase 1 and phase 2 clinical trials in Kenya. Her contribution to science has earned recognition from ASCO and being an early cancer scientist, winning an early cancer scientist award. So welcome, Dr. Chemutai. So this evening, Dr. Chemutai is going to talk about purpose-driven careers, lessons in global health, research, and women's impact in oncology. So we shall set off in the evening by having a short presentation from Dr. Vanna on legacy and leadership, and thereafter we'll have a few questions for her after her presentation. Thereafter, after we go through the 4 women in oncology, we'll welcome questions from the audience. Thank you. Professor Vanna.
Thank you very much. I think Kesha will share my slides. I'm just is Kesha sharing my slides? No? I'm sorry, we agreed to share it, so I don't know why. Yeah, okay. All right. Sorry. Okay, so I'm just talking a little bit about legacy and leadership. Sorry, I get a little bit distracted, so I prefer to present my slides. It's about mentorship from women advancing cancer oncology in Africa. So why do we need leadership in cancer research? Everybody will ask, not just about oncology in general, but we know research is the center of why we move. Just to make sure our research is sustainable, it is innovative, it is patient-centered, which is where we are all gearing to, making sure that it's patient-centered, and that's a lot of work. And it's context-specific. Our continent is very special, and I think we need a lot of leadership to focus on what is important to us and guides us to what to communicate to the world and also among ourselves to make sure that this is successful. Why do we need women leaders? There's no universal leadership program for physicians in general, let alone women. Although we are 75% of the workforce, but only 25% of us are in any leadership positions at all. We all know that women carry the heaviest burden of cancer. As caregivers, we are able to have the upper hand to direct how oncology is practiced on the continent, or what is important to us. We navigate the terrain from our daily experiences in and out. Many women fall astray from several confounding factors. I'm sure we all have good examples, but many also are able to navigate. How many are really navigated through this process? Sometimes something gives, yes, but we are still resilient and we move this forward. There's a light at the end of the tunnel, which is us, and this brightens the path for other people, or else we all fall astray along the way. But with that, we also tend to increase respect from other gender to see that we are able to achieve and also excel, and because we have this natural instinct to lead. Why do we crave gender diversity in research? This I got from the Lancet Commission on Women, and it looked that we need gender and power balance in everything we do, because across the continuum of prevention, early detection, diagnosis, and comprehensive management, we look at things from the individual, interpersonal health system, and sociocultural context, and each of them is specific based on our gender. So that's the more reason why we need to outline why we need gender-specific roles in our practice, in our daily work, and also in research and the way we guide the continent in how we come out with our oncology. And again, this is another slide showing you in high-income countries, we have for one female, there's a male leader. However, in most of us in low to middle income countries, it's the reverse. For very high quality organizations and leadership roles, is mainly the males. And when it comes to things like charities, advocacy, they're more like secretaries and support groups. And I think this needs to change because we are able to do this and be able to be examples to other people. Leadership experiences are a lot. I'm not even going to go through them because so many people are going to talk about it. So I'll go over this. Right? But just to say there's a balance between the behavioral traits from female versus male leaders. Females are meticulous, autonomous, and socially confident versus male. They are also rational, decisive, and stress resistant. But you need a good balance of these two to be able to move anything forward. If it's straight, if it leans on one side, it is not good. Leans, but both together works out well. So female leaders right at the top, alternative with male leaders, or vice versa, to have a good balance, because we are naturally leaders to make this happen. So this is a slide from a recent slide from looking at otolaryngology. It's not only oncology, but in other fields of medicine. You can see that they looked at 13-year review of annual meetings for otolaryngology. So when it came to session moderator, executive council, interest group, executive committee, regional representative, the females did very badly. There were no leaders in the gender representation in terms of leadership and research. And that echoes across almost all the oncology, specialties. This again is another slide looking at the gender inequality in health leadership. This was just recently published, looking at all the challenges and facilitators. I don't have to go through it, but unsupportive work environment, intrinsic elements, practical approaches, support systems, and struggles of dual responsibility. We all know this, but then this is what makes us stronger. And then by standing up where you are to lead, you are a shining example to others, because it looks like it's almost impossible. We have so many surmounting problems, but it's only through guidance, through navigation, that we're able to overcome. And once one person does it, the others will follow through. You are a shining example wherever you are. But then looking from the LEADS framework from the Canada Health Professionals, leading yourself is number one. That means you have dedicated to isolate yourself, to be a champion wherever you are, to make sure you succeed and other people succeed. You engage others along with you, along the path. Just the way that you're able to nurture children or nurture people in your family is the same way we are able to nurture our colleagues and our networks to be able to achieve an impact. We want to achieve positive results. Those are one of the most important things to us as women. And based on that, we are able to achieve more. We develop coalitions and networking wherever we go, because we are not biased, we are not proud. We are able to segregate wherever we are to develop coalitions and not keep things within ourselves. And based on all these, we are able to develop the system. I think it's more so for females. That's why I actually chose this slide. And also, there's a recent study that looked at the role and impact of women leadership somewhere in Africa, looked at the Thrive study. And what they found of that, they looked at 137 articles. It was a scoping review. And they realized that in the healthcare sector, women did wonderful with financial performance, risk and stability, innovation, engagement with ethical and sustainable initiatives, health outcomes, organizational structure, influence, and on other women's careers and aspiration. And for me, number 6 is number 1. It is so important, okay, to make this happen. And women have a special skill to be able to let this happen. So what are the positives we can learn from sub-Saharan Africa? It's a fast expanding workforce, mostly women. We have to remember that. And we need to harness this and hold on to it. Aortic, for example, has a large female leadership. I'm sure the same with Keshu. So we can see that the narrative changing, that we have more female leaders. And I think we aspire to be examples for the rest of us, not to be afraid, okay? Miriam Mutebi did a study and look at there's so many first female authors in Africa compared to other even high income countries. So it means that we are winning, but how do we make this translate into outcomes on our continents, in our programs? We do a lot of leadership programs for women now, but I think they are in different silos. We need to be able to merge them all together to have a positive outlook for for us on the continent to come out strong and lead even better. And we need to be you consider ourselves as role models. Nobody is isolation. We should always remember that whatever we do, you are sending a message of resilience, of power, okay, and achievement to your other young females. There's a lot of changing family dynamics now. A lot of women now are the breadwinners. A lot of the women are now in the workforce earning money. And I think we could turn this around into power, into making sure that our outcomes are much better on the continent in terms of our cancer patients. Thank you very much.
Thank you, Professor Vanna. Very, very powerful, very good evidence on leadership. And the other thing is, also very good evidence of creation of legacy in the context of oncology that women can actively build through their career in clinical work, in research, as well as in training. Dr. Vanna, how can we create mentorship networks across Africa? How can we strengthen this support for the next generation by being the sort of leaders in oncology and that we are today? And how shall we collaborate in advancing the individual careers and advancing the cancer care systems that women are involved in? How can we do that? Is it, what shall we create so that we can mentor women and we can be able to collaborate with them so that we can become leaders and leave a legacy? I don't know, in your presentation, you've shown us how leadership can be done and the roles that we have to play, but how can we mentor others and how can we collaborate, Professor, with what you know are the existing networks?
So I think we need to make ourselves available. That's number one to me. Most of us are like a wall, so nobody can really approach us. I think that's my first problem. And also, we need to go out and fish, be fishers of men, like in the Bible. And I think that's something that a lot of us do not do. You need to, hey, come here. What's your name? What's your institution? I think this opens up a lot of doors. What's your email? Send me an email on what a lot of people don't like to collaborate. I don't know why, but it's so easy. Just by opening up yourself, giving a smile, just to, and sometimes they even know you. You didn't even know that. But because you never smiled, they never really got to you. But so by opening up yourself, you'll be able to go and fish in your institution when you travel. It was beautiful at Aotic this year. So Nazik and I went fishing for all these females, trying to interview them. What are you doing? What are you doing next? And they have a lot of negative experiences, and so do we. But we overcame them. Put yourself in their situation, and that will help you to advise them and let them make it easy for them to come and meet you anywhere online, virtually. I think we have a plus now being online. A lot of things can be done. Also, I'll say also include other people in your mentorship network. So not just you, but engage other friends. I know it's difficult. Some people fall along the way, but it's just by a positive, feedback, and encourage other people to enjoy. So I think we need to have a big network. This is number one. I love this. Eotic also tried. It hasn't been that successful. It's not that easy to deal with leaders, especially the young leaders. Everybody has so many things to do, especially money. In Africa, we need to look for extra money because our salaries are never enough. That can also cause its own problems. But we have to teach our women how to navigate this so it turns out positive, both your family and your career. I think you can win, with that. So I think we just need to fish. We need to have an unselfish, method of being able to grab other people. It is so necessary for us to survive, or else we are going to fizzle out. I think it's very important and teach people how to do that. I think that's important to me.
Thank you very much, Professor Vanna. Availability, being fishers of men, and also trying to network and include other leaders and legacy creators in our mentorship journeys. I'll welcome Professor Nazik Hamad now. After that powerful presentation by Professor Vanna, we ask Professor to talk to us about leading with purpose. We are very poor in Africa. What are the lessons in global oncology on mentorship and building impactful careers so that we don't waste time, we don't waste resources, we don't waste opportunities? Welcome, Professor Nazik.
Thank you so much for inviting me. It's always a pleasure to participate. And I want to thank Kesho for remembering this very important day especially for African women and girls. Are you able to see my slides?
Yes, Professor, we can see.
So I was asked to talk about building impactful career in global oncology, mentorship, leadership, and equity. So I will stay true to what I've been asked to do. And I think because I was asked to talk about global oncology, I have to start with saying we cannot have impactful careers without sense making of the world that we live in, because the world that we live in as African women or women of African descent is changing. So let's talk about global oncology. And to do that, you need to talk about global health. So the definition of global health, traditional definition, is an area of study, research, and collaborative intervention that prioritize improving health and achieving equity for, especially for vulnerable population around the world. And it also aims to eliminate health disparities in local resource setting. And so it's different, and it looks into emerging health challenges, social, cultural, economic, and environmental factors that underlie the health equities and inequities, and it's different from public health and international health. So when we say low resource setting, it could be two settings. One is local, in your own environment, in your own country, the geographical disparity, the income and wealth disparity, the race disparities, the gender disparities, and again between HIC and LMIC. So we do have global oncology within Sudan, within Kenya, all with it, because we have local disparities as well. So I want to start with that definition. The other thing, I think it's time for us, given what's happening around the world, is to come with new ways of thinking of global oncology. And the way I would like us to think of it as people of African descent and global health. And so I would like to think of it as global Black health and global Black oncology when it comes to cancer. And so in between 2015 and 2024, the UN came out with the International Decade for People of African Descent, recognition, justice, and development. A lot has happened, but COVID-19 has eaten most of that period. And so the UN came up with another call for the second International Decade of People of African Descent to renew the call for recognition, justice, and development. And this was it's going to be between 2025 to 2034. So this decade is ours. And so if we look at Africans and African and diasporic Africans, these are the people of African descent. And I think this is a way we need to talk about global oncology. Here we are in Africa, especially sub-Saharan Africa, and then or a billion of us. In the United States, there are about 40 million of us. In Brazil, there are 15 million. And as you go, we are scattered in Haiti, in United Kingdom, in Cuba, in Spain. So we are all over the world. And so women of African descent, what brings us together is that most of us live in a low resource setting, where in the continent or in the diaspora. And so the urgency is that what happens if you live in low human countries that have low human development index, HDI, is that according to our work in the Lancet Commission of Women Cancer, is that 72% of cancer deaths happen were premature, younger than age 70, compared with 36% in countries that ranks very high in HDI. And when it comes to breast cancer, about in high-income countries, only 5 to 10% patients present with metastatic disease at initial diagnosis. But in LMIC, de novo presentation with stage 4 and 3 is 50 to 60%. So high disparity there. If we look at what's happening to Black women in the US, we have what we call the 440. They have 4% lower breast cancer incidence than white women, but 40% higher breast cancer mortality. It's a disparity that has remained for the past decade. In Canada, again, we see that this data come this year. Again, breast cancer mortality by race, Black women have much higher rates of deaths, especially between the age of 40 to 49 compared to white women. And we see this from Brazil in 2023. There is a much lower breast cancer survival. And this is just taking one cancer. And so does increasing access close the gaps by racial disparity? We know in high-income countries this does not happen. It's not sufficient because there are other factors that determine prevention, early detection, and treatment. So, if you follow the literature, there is what's called allostasis, or the allostatic load, is that the physiologic response to stresses at baseline and upon resolution of these stresses. And there's more research on it in Black women outside Africa, but I think it's time for us to look at it. And it does, in breast cancer patients, you can have actually objective measures: systolic blood pressure, diastolic blood pressure, total cholesterol, C-reactive protein, and we have worse, this is one of the reasons we have worse outcome. So you asked me to talk about equity. So this just came out into 2025 and about inequalities in sub-Saharan Africa. Unfortunately, Africa has the highest income inequality globally, between the large gap between the top 10% and the bottom 50%. And the inequalities within Africa within countries have remained high or increased. And it's mainly driven by within country disparities. And the wealth is not, sometimes the wealth inequality is higher than income inequality. So wealth is heavily concentrated in assets like housing, pension, and financial assets. And so again, gender disparities exist in asset and land ownership, and women owning less and having less control. And then we have the triple burden of disease. We have unfinished agenda from malnutrition, reproductive health, NCDs like cancer, mental health, and then the pandemics, and what's emerging health threats to African women is climate change, or we call it climate injustice and conflict. So if we look at climate injustice, is that we have not caused degradation because we do not emit so much greenhouse emissions, but Africa is bearing the brunt in rising temperature. We have the highest rising temperature, droughts, floods, loss of infrastructure, conflict, and displacement. And so the inequality in vulnerability to climate shocks is also determined by gender. So in Kenya and South Africa, female-led households generally more vulnerable to climate change than male-headed households. And so, when it comes to cancer, mortality rates increased by up to 332 deaths per 100,000 women for each 1 degree centigrade increase in temperature. And the strongest list for women cancers: breast, ovarian, cervical, and uterine cancer. And this is research from 2025, this last year. And so it's not only us in Africa, but also the people of African descent living in Haiti and other parts of the world having a lot of devastation from tornadoes and others. So this is racialized vulnerability. And if you look at the conflict and health, Africa these are the countries that have conflict in them. There are more than 16 countries in Africa have conflict, but all the attention goes to Ukraine and probably to Syria and to Gaza, with little focus on that. And what does it do? We have now what we call, in order for us as women to understand the effect of this on women, we need to look at complex therapeutic geographies, from climate injustice, the nexus with conflict, as various geopolitical conditions. And this has a devastating effect on women health and women and girls, and treatment, disruption of cancer treatment, and predisposition to cancer. And then the new macro trend is that there is decreasing global funding. No money is now coming from the global north or from donors. So it should be us about us now. And so just to tell you, like, this is my recent trip to Uganda, the suffering of displaced people, refugees, is that even when you have universal health coverage, you still don't have access to treatment. And so we need to approach global oncology as African women, as knowing our place in time, geography, and history as women of African descent. So this is the background. Having this background, how can we have impactful careers in global oncology in terms of mentorship, leadership, and equity? So I'm not going to go over this paper. We published this paper in 2023, and this is the work that's done by Aortic Task Force for Women. We talked about the challenges faced by women oncologists in Africa, and we looked at mentorship, the challenges, the solutions in terms of being a mother, being even like asked to be participate more in community activities such as wedding and funerals, all the way from clinician, leader, and in the global context. We do not, most of the time women are not given grants compared to men. And most of us have asked for increasing accountability and reporting mechanism from our institution. So when it comes to mentorship, the challenges, as Verna mentioned, smaller pool of mentors, intersecting workload, personal and societal demands on the mentees themselves. Sometimes I approach mentees and they don't make use of the opportunity because they have so much work, and so that causes difficulty in maintaining mentoring networks. And also, when it comes to cross-border mentorship challenges with HIC mentors, you can have mentors from the UK or Canada, or especially if they're non-African, you can learn a lot from them, but the context relevance is not there. And we also have lack of platforms to bring Black women from around the globe together. So what's happening to Black women in Brazil is really a very bad situation, but we rarely ever know about that. And so now came the new concept of oncology, anthropology, and the African diaspora. And this group is leading this work in breast cancer, looking at the intersection of generational, genetic, and socio-political factors influencing variation, for example, in breast cancer outcome and disparity. And this is the type of work that we need to work on together. And they're looking at diet, excess body weight, and all the other societal factors. So I think I would ask you to avail yourself to this kind of knowledge. On the other hand, we have a lot of advantages. We have shared history. We come from African lower middle class. We have shared colonial and post-colonial experience, and it's easy for us to come together. When you see us in a Wartik or in Keshore, when we see other, we love each other. We always like to work with each other. So what's happening is that we are good citizens, but usually there is and we have good representation in Keshu and Awartik and others, but most of the time there is little recognition in promotion of academic leadership. And so we need to change the culture. We need more academic opportunity for women and change an archaic and colonial promotion recognition criteria. Why? Because women work more in organization, maybe because it's a democratic process. So you really get you have elections, for example, in Awartik, but in academic departments, it's more hierarchical, male-dominated, autocratic process and glass ceiling effect. And women are more likely to volunteer, be more involved in advocacy, but less likely to get grants. And so we need to value women in leadership and contribution. We don't have to have the same leadership as men in terms of domains, but we need to value whatever we do, even if we do, like, for example, advocacy. That's a leadership, and that's very important. And so we need to change culture. So what do we gain from advancing women in leadership, as Verena mentioned, despite class privilege? Because we are in medicine, for example, we have more, just by being a physician, for example, or a nurse, you are in a higher socioeconomic class than your patients, for example. But we're still more likely to have solidarity with women from lower socioeconomic backgrounds. And we also know that there's increasing feminization of poverty. Women are becoming more poor, and they have a lot of intersecting adverse factors affecting Black women health globally. And so we tend to have more understanding or nuanced understanding of that. So this is my last slide. So when you talk about impactful career as an outcome, what does it look like? And as Verna mentioned, it's being a role model. So you need to engage in mentoring and strengthening mentorship networks. The other thing is you have to demonstrate or strive for excellence in knowledge production, like research, for example, teaching, advocacy, and policy making. You can do all, or you can do one of these, but at least whatever you do, you have to be excellent in it. And this should be informed by deep understanding of the global compounding and intersecting adverse factors in Black women's health. And we need to exhibit an advanced ethical standard that support equitable cancer outcomes for all women, for everyone, in particular women. So we need to, like value-based care, and also advocate for universal health coverage, and for advancing competencies in the workforce that support providing compassionate and respectful care for women, rather than blaming them for delayed diagnosis. We understand the sociocultural factors that led to delayed presentation. And so in this day of the International Women's Day, and especially for women of African descent, for people of African descent, this is our decade, and we should own it. We should empower women, and empowering women of African descent and improving their health, improving health outcomes for everyone around the globe, because we tend to have the worst outcome. So if we get better, everyone gets better. And so I would like us to maintain our mentorship networks and to strive for leadership and excellence. So thank you so much for giving me the opportunity.
Professor Nazik, that is a profound presentation about, the reality that there exists something called Global Black Oncology 2015 to 2024, where there is an international decade for people of African descent to concentrate on making oncology outcomes much better and trying to reduce the disparities in cancer care. There is also a National Association of Black Oncologists that looks at cancer care, advocacy, and the appropriateness of treatment for Black people. Professor, women are said to be their own worst enemies. And as you've said, we tend to be privileged because we're in the medical profession, and we should be best to understand what you've referred to as feminization of poverty. Now, Professor, I don't know, in your own personal career, when you look back at your career, what was a pivotal experience that shaped your journey into this great understanding you have of global oncology and leadership? Let's call it in Black global oncology and leadership. What was either single or multiple experience that has shaped this great understanding that you have today?
I think I get it to, first of all, my personal background in growing up in the White Nile area in Sudan, coming from, my father was a teacher, but the rest of the family, can you hear me? Yeah, the rest of the family still lived in the village, and they were extremely poor. And so I got exposed to wood, and I saw my aunts and my grandmothers working hard, doing from morning till night, doing all kinds of things. And so the idea that African women work hard, I've seen it with my own eyes, and I've seen how difficult for them to accumulate wealth, to accumulate and to have, and the power asymmetry, the decision making, and all of that. And then when I went to medical school at the University of Khartoum, we used to go always travel to the rural areas and spend a few days every few months or so. And also the patients who came to the public hospitals that we had, we saw the like women with getting breast tumors that they didn't even know that is breast cancer, and women having bladder cancer from schistosomiasis, while it's even more common in Africa than elsewhere. So all of these have even going to high income countries was like going to Canada was driven by the fact that we lived in a unstable country. There's a lot of socioeconomic factors that make you, for example, immigrate or create the brain drain. But that doesn't make you forget from where you are, and your family is still there. And still, my experiences with the recent war in Sudan, my family is displaced. So I'm talking to you now from Rwanda. where my 90-year-old father is in the other room, having been displaced from Sudan. But here, at least they are a little bit more privileged because they're here in Rwanda, living in a house. But as you can see from my recent trip to Ghana, we saw women in the camps. They are diagnosed with breast cancer. It takes them 6 months to finally reach, for example, UCI, although there is universal health coverage for them, but it's so difficult to navigate the journey to be seen. So all of these experiences are part and parcel of my, psychological and moral fabric that, determines what I want to do.
Right. Thank you very much, Professor Nazik. Unfortunately, we've lost Dr. Keria, but she's rejoining shortly. Dr. Muriki, perhaps we can hand over to you at the moment.
Thank you very much. I will do my own introduction. First of all, I want to thank Kesho and I want to thank my fellow panelists. What an absolute honor and privilege it is to share the platform with such great women who have so much experience in leadership in Africa and in our specialty. And, I feel I need mentorship to get off my imposter syndrome just now. So I have just been sent the questions. So I will just read my own first question. So mine was not a presentation, but rather questions. So the first question was, what motivated you to specialize in hematology, and how can young clinicians identify and pursue their niche? So we changed tack.
Yes, I got off, but please do answer. Thank you.
Okay, thank you, Gladwell. So, we've gone through the structured career mentorship, that all institution that's been created by these great women. And now I'm here to share my personal story. Several tiers beneath, but here goes. So, I always wanted to be a doctor from the time I was little. And when I was around 10 years old, my mother had a slip disc. So she was in hospital on traction. We used to go visit in time for dinner so we could eat her ice cream. And then when she had to come back home, she was on bed rest for a while. And my 10-year-old hands used to massage her back on request. So I developed an interest in neurology. And there was a little bookshop we used to go to. And I found a child's encyclopedia titled, I think, Human Body. And there was Brain and Nervous System, and I bought it. It had big pictures and big words, and I read about the spinal cord and the slip disc, and I was like, that's it. I'm going to be a neurologist. So eventually, I went to medical school, and then after that, I did we call it a medical rotation, we call it residency here, all focused to become a neurologist. All my projects were in neurology. And when I entered my last residency program, which was in hematology, something changed. Now, I had encountered hematology patients during what we called medical attending. So this is when you've been on overnight and you admit new patients, and there'd be a little old lady with the white cells of 30, and you wouldn't really know what happened, what was going on. And when you presented the case in the morning, all the attending consultant for the receiving ward would say is, okay, we better call Dr. Ano. And Dr. Ano was our resident hematologist. So at some time in the day, Dr. Ano will come walking up straight backed. He had thick horn-rimmed glasses and a little rectangle mustache, and used to come carrying this small metallic box. And then he'd go in, see this patient for what seemed like an inordinate amount of time, and then he'd leave the ward, and he'll come back the next day and he'll write on this patient. The patient would be wheeled off somewhere, and I'd never see them again. So this went on for the period I did my medical rotation, and then I ended up in the hematology ward for my last 3 months. So when I got there, some things were different. First of all, you didn't have, I was a senior SHO, senior resident, but we did not have free reign over the patients. We were not allowed to have autonomy over patient decisions. There was a buffer between us, the patients, and the doctor, which was a nurse. Then the second thing is you were allowed to do duties, but you just couldn't make a decision. The third thing was you could be ordering blood tests at the desk or writing a prescription, and the phone would ring and the patient says, "Hello, this is Susan such and such, or this is Mark such and such. I just wanted to report I have a swelling in my leg, or when is my chemo due?" And whoever you spoke to who was walking past knew the patient. And I was really amazed about this unit where patients were so well known, and I wasn't allowed to handle them, even though I considered myself quite senior. So I was quite intrigued. So I approached Dr. Aino and I said, "Listen, can I just see what you do with the patients? Can I go up with you?" So it ended up being Dr. Aino and Anne going up to see the patients. Needless to say, the whole workup, from the long clinical history to doing the bedside bone marrow to staining the slides and looking at them and then giving a diagnosis, just completely blew me away. And I thought, oh my God, this is it. Where has hematology been all my life? Oh my goodness. And I was coming to the end of my residency, and it was so serious that I extended my residency for 3 months to be sure I was convinced about this divorce from neurology. So in a sense, and so I joined hematology. I have never looked back. In a sense, I think hematology discovered me rather than me discovering hematology. And so I have that privilege that I know I'm not supposed to be doing anything else. So to the second part of the question about how does someone choose their niche, I would say, what interests you? What are your strengths? You know, I hate to use a cliche, but they say, if you do what you love, you will never work a day in your life. And I know Dr. Vanna says there's never enough money, so that's the only caveat, but it's true. I can do hematology at 2 a.m., at 5 a.m., after a party. I can always do it. I just love it in my bones. But the third thing, which is really important for our setup, is what is the unmet need in your area and in your region? We have a huge unmet need, and this is an interesting area. Even if you don't have it in your bones, it can develop. And if there's a huge unmet need that you feel is there that could be addressed, that's another reason to join a specialty. Yeah. So I would say for me, hematology found me. Yeah, but follow your interests and also address the unmet needs in your area.
Yes, and that was going to be our next question about what Professor Nazik has also alluded to, the disparities in cancer outcomes, the underrepresentation in clinical trials, the issues to do with genetic and environmental factors, the climate disparities she has talked about. What are those challenges in hematology oncology? Realizing you're a Black hematology oncologist, realizing the issues of global time, geography, and history. What are those unmet needs that you allude to? These disparities, this underrepresentation, and all the problems that we face. Which are they, Anne? You do recognize them.
Okay, thank you. I'll mention but a few, Gladwell. I would say, hematology is a place of many firsts. Sickle cell disease was discovered in the 40s, the first genetic condition, but our first licensed drug for sickle cell was 40 years ago, and we really don't have another licensed sickle cell drug. Transplant gene therapy for sickle cell is 20 years old now, or just almost 20 years old. For a disease that we discovered the management of sickle cell patients around the world, we can see that majority, 75% of sickle cell patients reside in Africa. Yet the greatest protocols, the access to blood, the access to transplant, the access to novel trials is not for that 75% of patients. Instead, we have piecemeal measures. We also have some predatory measures coming into our setup to in some ways try to treat us but take advantage of the setup we're in. So it's a bit of a dichotomy. We have the privilege of being kind of the oldest genetic condition, but still no real treatment that is accessible to most people. I think that's a major problem. But when we look at other conditions, let's take acute myeloid leukemia, for instance. Again, a lot of advances in hematology over the years. There was the 100,000 Genome Project, which ended in 2013. And even before that, we were able to find out there are lots of genes involved, mutations involved in the development of acute myeloid leukemia, which helps to diagnose, which helps to prognosticate our patients, and which helps to develop additional therapeutic measures which can help the outcome of our patients. Now, over time, it's been known, and it's become even more apparent now that even in the setup, so the first thing to say is that in our setup of absence of universal healthcare, absence of proper blood banks, absence of proper units to treat these patients, these conditions are expensive to treat. We thought that was the only hurdle we needed to get over. But we find that even after getting over that hurdle, our patients don't go into remission as often as the others do. Our patients relapse quicker. And then you find out in very recent times, the data says actually African patients have a poor outcome in comparison to other patients. It's the same thing with multiple myeloma, 6 times more common in young people, twice as common in adults. It almost feels like, yes, we have diseases that have the same name, but they behave so differently in our population that we need to read our own diseases. We need to understand them in depth. We need our trials in-house. We need a universal healthcare that covers our patients from diagnosis all the way to treatment and access to treatments in order to bridge that unmet need for our patients. I don't know if that full unmet need for our patients in a hematology context.
Very well said, Anne. In fact, I mentioned earlier that you're one of the few of us dressed in purple, which is the color for the International Women's Day. Now, Anne, you've talked very well about the complexities of our disease, the complexities of therapeutics and of geography. I'll move quickly along to one of the young Africans who we are very proud of, Dr. Chemutai. Of course, we can see that you've had what Professor Nazik has referred to as privilege in medicine and consequently in oncology. But we're a little curious about what has inspired your focus on global health, and especially on cancer prevention. And basically tell us how you found your niche in oncology, Daktari. And welcome to Kesho.
Thank you so much. Thank you, everybody, for having me. It's such an honor. I feel like I'm going to church this morning or this evening, just being in the presence of such amazing women. Thank you, Professor Nazik and Professor Varna, for paving the way. Thank you, Dr. Ann, for what you've said. And yeah, I'm just really honored to be here. So I am a gynecologist, and a lot of what was said resonates for me. How did I get here as a young African woman who's leading science to impact the lives of African women? Like was mentioned by others, I grew up in Kenya, and while I grew up in a middle-income country, My parents were the first generation to, I grew up in a middle income household. My parents were the first generation to ever go to school. My dad was the first in his village to ever finish high school. And within a generation, I got to attend the best medical school in the United States, and now I'm a professor in one of the leading research institutions. But I carry that history of seeing poverty firsthand, of seeing the disproportionate burden that women in Africa face. I call it the disproportionate burden of poverty, patriarchy, and weak health systems that impacted my grandmother, my mother, all the way, all of us who've grown up in Africa have stories, and that's what motivated me to. I was good in science and math. I went on to become a physician because deep in my core and in my bones, I wanted to improve the health and lives of African women because I grew up seeing that significant difficulty, the pain, the suffering that specifically women in rural areas experience. And increasingly the science is there, but it's a lack of access, it's a lack of prioritization, it's the issues of patriarchy, it's the issues of our health systems. So what motivated me to be a gynecologist was leading clinical trials. So for example, I trained as a gynecologist and did my training in the United States. And here, and I spend my time between the United States and Kenya. And as a gynecologist in the United States, I almost never care for a woman with cervical cancer. Cervical cancer is one of the cancers that we have figured out the science to a very large extent. Yet 90% of women who die from cervical cancer are African women, often women in low and middle income countries. So again, seeing this really significant disparity where if I'm in San Francisco where I trained or North Carolina where I work, it's very rare to see a woman with cervical cancer. And then when I'm in Kenya and you go to the wards, in the gynecology wards, there's a lot of women with tumors, with bleeding, who are dying really horrible deaths. And it's because of the lack of ability of our health system to bring the science to bear for these women. And of course, this tend to be, poverty drives it a lot. I love what Professor Nazik said, the feminization of poverty. When poverty and work health systems abound, it's women and poor women who bear the brunt. So for me, it was this deep passion to make a difference from seeing my grandmothers who never went to school, never saw a doctor. I like to tell the story. This might be the first time I'm saying it publicly, but my maternal grandmother worked for the colonialists in Kenya. So she was like a maid for the colonialists. And my mom tells the story of when she was a child, her grandmother had broken her arm and, really poor, didn't have access to being able to get, the care or get time off. So my mom would help massage my grandmother's arm with hot water, and so she could work. She couldn't show her employers that her arm is broken because she could lose a job, and she desperately needed the job as a single mother, etc. So it's those things that really drive me, and then drive me to use the privilege that I've had to have excellent education and to have the opportunity to do science. And again, if we ourselves don't drive the science, unfortunately, we live in a capitalistic world where sickle cell, drug companies make drugs that make money. And, if the African population is seemed that, there's no money, so sickle cell, there's no innovations in sickle cell. Clinical trials in cervical cancer that are killing African women very needlessly. If you look at the clinical trials happening globally, very few of them are happening in sub-Saharan Africa. So it's us driven by our experiences to say, hey, I'm going to open a clinical trial. I'm young, I'm doing this, I'm learning on the job, but and the more of us, again, pursue that excellence and connect excellence, unmet need, and our passions, the more we can move the field forward for African women.
Very well spoken, Professor. And you bring out what we call racialized vulnerability, which Africa is, especially with cervical cancer. So in the aspect of social accountability, Chemtai, who mentored you and how was that path? Who do you remember in particular? And what circumstances, mentored you? You've spoken about your family, about your grandparents and your experiences in Africa, but there were special, people who led you the way, especially women who you looked up to. And in the same way, please tell us how you also mentor how you mentor others, leading them into oncology research and also patients into better outcomes.
Yeah, thank you. So mentorship is key, and we, so who mentored me? I start with, my parents helping set me up, setting the stage, giving the example. As I went through school, and I think this is a lesson for everybody who's starting their careers. Look for mentors in all shapes, colors, sizes. African women, Black women mentors give you something very specific, but there's just not enough of us. So one of my key mentors, his name is Craig Cohen. He's an American white man who's a gynecologist, but he, as well as Dr. Elizabeth Bukusim, who many of you know. But Professor Craig Cohen was a professor at my medical school. So when I was applying for medical school this year, 20 years ago, or more than 20 years ago, I knew that I want to improve the health and lives of African women. I applied to medical school, and there was this professor called Craig Cohen who was working in Kenya, working on HIV response. So I reached out to him and told him who I am, and over the last 20 years, he has mentored me, and I would say he's the person who has helped me most in my journey. So I think the lesson there is to find, reach out to people, and you can get different things from different mentors. I can't go to Professor Cohen and talk to him about racism that I face as a woman, Black woman in medicine. He'll have ideas, but he doesn't have the lived experience. But I got a lot of scientific mentorship from him. So that was, finding people who you see doing the work that you want to do, and then keep going over again. Everything takes time and it's very slow. I am, the early part of my career, but certainly I love the people that I'm mentoring, for example, are my research team. I lead a research team with a medical doctor, nurses, and we are trying to do science that we hope will change the face of how we treat cervical precancer for African women and save lives. So I spend a lot of time trying to articulate the vision to them and to get them to be ambassadors. I work with students that I try to mentor both in Kenya and here in the United States. So find mentors from different places. Different mentors will give you different things. And then all of us who are starting our journey definitely are working to mentor people. Of course, time is always a challenge, but, in the studies we do, we always have students and trainees. And certainly, the hope for I is that as I grow in the next 20 years in my career, I will leave others who can keep on the work.
So thank you very much. Very insightful response. And we are sure, with the networks even created in this forum, many people can reach out to you to collaborate in research in this international decade for people of African descent. I'll go back a little bit to Professor Nazik Hamad. And Professor Nazik, you come from also, an area that is a sort of low to middle social economic areas presented to us in our OTIC many times and also in our school. told us about the disparities that women suffer in your country of origin, especially what you've alluded to today about the climate disparities and the effect on outcomes in women and in training and in creating oncologies. What practical advice would you give to early career oncologists seeking to build meaningful and purpose-driven careers? We've heard this evening that we should be totally intentional in our choices, in our seeking mentors, as Professor Chemutai has said, and also having different sort of mentorships so that you can get different things from different people. What should an early career person, how do you position yourself to be able to have access to all these things which will make you an oncologist to remember?
Thank you so much. I think you start, we had some faculty development sessions, and everyone should start as they went to oncology, so they made the right decision, first of all. Congratulations. That's the best thing to do, number one. Number two is to, as they are finishing their residency or their fellowship, they should start to think about what do they want to do in the next 10 years, or they should look at their mentors and see, do I want to be like this mentor, for example, who's an excellent teacher on the ward, but doesn't do research, or like someone who is does administration, is an excellent administrator, or someone who does only research and see. And so they should sort of like, what do, again, as Anne said, what do they like and what do they want to, they find themselves in. And so based on that, even if they initially it's difficult to do, they should always try to find mentors. And I have to say, this younger generation, upcoming generation, is much luckier than us. Because when I was in medical school, we did not have any, you have to go to the library and fight over a Lancet, journal that's in there. But now they have access to online learning. They have access to Zoom meeting. They have access to emails. They have access to WhatsApp. And so the most important thing is the initiative around for who can mentor you. And then also know the ecosystem of mentorship in Africa. We talked about the small pool of mentors. So you have to be very intentional. First of all, you have to know that these mentors, whether they are men or women, especially if they're women, they're very busy. So you have to be persistent, but also respectful of their time. You have to ask them, what is the best way to communicate? Is it through WhatsApp? Is it through email? If your mentor is communicating with you, you have to prioritize your response. So if someone is very busy and they send you an email, you should always answer that email, not be a WhatsApp person only. So the way you communicate with your mentors and the way you show your interest, the way you approach them. And so, as Verna said, sometimes they may look intimidating, but as a matter of fact, I joke with Werner and my other colleagues. What we do is we are going on a talent spotting shows when we go to K-Shore or what. We talk to the young people. What do you do? Because we are eager to see what they are doing and how we can help them. I may not be able to help them personally, but I can broker opportunities. And this is actually, I have been doing more of that than doing the actual mentoring myself. So be intentional, be bold, but respectful, be communicative with the right communication. And then the most important thing is deliver. Deliver, and if you are if you're given a task like a review or a manuscript or whatever it is, try to deliver. If you can't, for example, because you're too busy on the ward or too busy with the clinics or you're having a baby, make sure to communicate that you can't and why, and put a new deadline. So respect deadlines, because it's not the matter of if you don't respect your deadlines, people will not take you seriously. And so all of this together with reading widely, having a global perspective, knowing about things not just the most recent clinical trial, but what does this clinical trial mean in your setting? Can my patient access this clinic? That's in the clinical setting. And then asking the right question, the question about how can we bring treatment closer to home and to the largest number of people possible.
Thank you very much, Professor Nazik. I think Dr. Gladwell's fallen off a little bit as well. Again, I think there's a problem with the power in the weather. When I look, that is just so excellent and comprehensive, this question. And I also think on a personal level, I always think to myself, how humbling our role can be. These journeys we take with a patient are not, it's not a day or a week. It's often for years, decades, sometimes until their death. So I always feel like it's such a privilege to enter this vulnerable space with this patient. And, when they tell you, okay, you have to have a good bedside manner, you have to work hard for your patient, I always feel like if I have a spirit of humility about what I'm doing, it compels me to listen to the patient closely. It compels me to have a good bedside manner. It compels me to make sure I have done my due diligence in diagnosing them, in making sure I've given them the right treatment, even when they're not responding to treatment. So I always feel like I'm not seeing that in any guideline or any book, but I think if we just have a little bit of thought about how vulnerable these patients are in this period they're interacting with us, in a sense, it also compels us to be better, compassionate physicians, and also for our trainees. Yeah. So thank you. I think Gladwell has come back. Gladwell?
And sorry, Anne, for giving you that responsibility. Sorry. Thank you for the excellent answer. And I want to challenge Professor Vanna. Now, she told us that, we talked about disparities of gender, of race, and we've had even climate changes. And she did mention that we have to work hard to make money. So, Professor, you've been in aortic. You are a co-editor in a research publication, a journal as well. You told us to be fishers of men. Now, Professor, with the legacy you've created, the leadership, what are the key lessons that you learned out of mentoring others? Remember, we did mention that some don't want to be fished, or some, Professor Nazik has said, nobody recognizes the opportunity of what she's offering. Having been in those positions, having learned that you need to be a fisher of women, what are those lessons you've learned from mentoring others, sometimes who are resistant, and how can they be taught to shape their legacy? And Professor, feel free to use aortic as an example, Kesho as an example, and these 4 great women who are in this panel today. What can they do? How can we be fishers of women? Thank you.
Thank you very much. I think a lot of us tend to have a little bit of a chip on our shoulder. Sometimes as women, it's a fact. We tend to be overwhelmed, it's a fact. And sometimes we have this blanket on our face that people can approach us. So I think we need to start with us. Lead yourself. So you have to lead of yourself to make yourself open to other people to also learn from you. Okay. So like Annie said, she went up to a mentor and said, I want to follow you. That's something that a lot of Africans do not do. So how do we need to, while we are teaching, we need to let them know that they can do that. There is nothing wrong with that. Of course, when it's male, female, then it's another problem. But you can start with the females first, you understand? And then you can find a soft-spotted male that might not misunderstand what you're trying to say. But you need to go. So she fished. Okay, she fished as well as the mentee. And that is something that is missing. We tend to want to be the mentors are the one fishing. It should have been the other way around. But I think we have different dynamics, where we come from. Also, I realized that those who tend not to want to be fished actually tend out being your best mentee. So I think we should learn also not to give up, on them, but rather give them more encouragement. It's so funny now that I'm not in the public service anymore. I'm still affiliated with the training of my residents, and so many of my residents are sending me messages to come back, to come and help them. okay, to come back because they understand that they have not experienced what they have to experience from me. I do it jokingly, I'm laughing, I'm cracking jokes, but I'm doing it. You understand? So, and that is a way of breaking the ice with our residents, male and female. Okay, female even more because they have specific consequences, which I have experienced. Childbirth, marriage, making sure you obey your husband, you know what I mean, culturally. Very difficult, but it's something that you have to do to keep your home, be an example. Because we say most women, what we say is that no offense to anybody on this field, but most women who have achieved have failed in one part of their life. It is not true. And also you have to choose what is important to you. So don't use one person's life as a guardrail for other people. No, everybody is an individual. But what I realized is that each mentee is different. It's very funny. I have a mentee who said, be like you, always on the internet, always this, going for meetings, giving lectures. But then I'm like, oh my God, I'm becoming like you. Say anything. But then I think they realize the importance of developing themselves just by looking at what you do. You understand? And sometimes I go and choose, you do this before they are angry with me. Why are you asking me to do this? But and you can see the passion. We have clinical oncology in Africa, radiation and medical. I don't want to do any radiation. I want to do chemo. I'm like, no. That is not true. You cannot do medical oncology. You better stick with radiation. Or like, I don't want to do any medical oncology. I want to stick with radiation. No, you don't stick with radiation. You have to do medical oncology because it's like an inherent thing that you pick up along the line from your dealings with them. So it's tough at the beginning. And also remember that everybody is an individual with what they want to do. You really can't shove it down their throats. They might actually come up with an innovative aspect of what you've taught them. Okay, and you also learn along the line how to deal with individuals. I guess also we tend to be a little rough, maybe me, but you have to remember and soften it down the line. And another time, apologize if you have to. Okay, somebody doesn't want to write 150 papers, but it just comes naturally. Like I like the way Annie put it. You just start with one paper, then 2, 3, 4, 5, 6, 7, then collaboration. That is just how it works. Okay, and sometimes everybody is different with what they want to do. Some people who like to teach a lot without publishing. That's what they want to do. They don't even realize they are doing research, but they are. And that's how you need to encourage them and give examples of how it is possible. Because you cannot maybe expense money. The balance is so difficult, especially for us in Africa where we don't have. I had this fight with Nazik many times because she has a fixed salary and I have to fish for money. Like you said, you can see I'm doing so many things. Just trying to keep the purse open because we love the luxury goods. But, the thing is that you need to be able to balance it out so that you don't suffer. One of them doesn't suffer. And that is a skill. Believe me, it is a skill to be able to. And some people can actually learn from doing that as well. I believe that you should be the best that you can be. Of course, with guidance from spiritual guidance as well. You cannot do it by yourself. And then highlight what is important. There are some things you just cannot do and you just let go of those things that you cannot do, and encourage other people. Say, no, this is not for you. I think if they come back and say, I still want to do it, why not? You encourage them to do it. So on our continent, things are very difficult because you don't have the money for research, the money to travel for your conferences. It makes it very, very tough, but just encourage them. Just one a year, try and apply for grants. It's also very difficult. But the most difficult thing for we Africans is when you are rejected from a grant, you almost drop everything down and run and say, I'm not interested anymore. So the same thing with a paper. When the paper is rejected, oh my God, you don't want to write again. But if you teach everybody that is the way to learn, go back to the reviewer comments. And at the beginning, you're angry. Go back and read them. They were absolutely correct. But it's a way of learning. And so you have to encourage people that you learn with the negatives. And I think that's something that is so important that we don't get across. Try and put in an abstract. It might be rejected, but you can use it for another paper, another study, or try and make sure you publish everything that you just wrote on paper as a joke. But most importantly to me is mentoring others as you were mentored. That's how we grow that mass. That's how you can sit back and say, I'm retired, because you know that whoever else is in the field is able to take it up and also be a mentor like you. Thank you.
Thank you, Professor Dr. Vanna. Now, what you raised about that we shouldn't give up, that we should stay connected and make the real world impact is very correct. Now, Professor Nazik spoke about, we come from problems, we live in problems, we are not financially able, but we must maintain excellence. That means, Professor Vanna, that probably when you see that name is an African name, in this global Black oncology decade, call them out, hold their hand, and help them to get back to the publishing table. I think we're saying, we are not compromising on standards, but probably saying that we should reach out to our fellow sister, to our fellow Black sister, so that we can be able to bring them up, at the same time maintaining excellence. Professor Nazik, how will we remain grounded to our realities, at the same time seeking perfection? Do those two words actually go together? It's very true. If you apply for a grant, I usually say, these people are being racist. These people even don't want us Africans and so on. And sometimes that's not actually the reality. How do we stay grounded to our realities at the same time we're seeking perfection? And, how can those around us actually handhold us to that perfection, Professor Nazik?
Actually, as a matter of fact, grants are important, but sometimes asking simple local questions, you can do a lot with if you have a good network of people around you and a platform. So, for example, a lot of the research that we did and papers that have been actually cited over and over again, for example, with Verna and with others, we did it through a Awarding platform, through surveys, through very minimal, funding. And there were the questions that really mattered. Of course, doing a clinical trial or maybe you need money for that, but not for everything you need a lot of money. And now, as I mentioned, the funding like this gave is getting worse and worse. So we need to really do two things. One is advocate for more for our governments to have more funding and give they promised us that they will give 2% of the GDP or more, and we need to hold them accountable for that, and then also look for ways to collaborate and ask questions that will not need a lot of money in order to do some research. So it should not stop us, especially with the right network of people asking questions. I also wanted to, another thing to ground us is Chimpe mentioned, it's like really who we are. We should never ever, yes, sometimes we join the upper middle class. We may have better cars than everyone else, but we should never forget that, especially we are more privileged actually than, for example, my white colleagues, because the gap between me and the poor family is very, in terms of time and in place, because it's still, there are lots of people I know live in the village. There's a lot of, my mother just finished grade 4. She didn't have any education beyond grade 4. So all of these are quite very recent, very palpable, and we should strive to make them remain palpable and relevant in everything. And they should inform, as I said, our ethical standards as we go. The other thing regarding being grounded, as Brenda mentioned, that sometimes women, the child, years of like giving birth, having children, and societal expectations, and all of that may seem like they derail your career, but sometimes you actually acquire a lot of skills doing and navigating all of that. And so I want to say to young women who are in this stage in their lives, do not give up. Even if sometimes your male counterpart, because his wife is taking care of the kids and they're traveling everywhere and you can't do that, sometimes you can actually have accelerated growth and accelerated performance because of all the skills that you have accumulated navigating all these complex roles. Having said that, we should still work hard to make sure that we have equity, we have, good salaries, we have, parental leaves that are good. Men should also participate in the household. We should also have men advocate for us, because we still, for African men, this is your daughter. This is, even if the wife does not seem like has, as I say, the war of the sexes, but at the end of the day, It's your daughter, it's your mother, and it's the future of the continent as a whole.
Thank you very much, Professor Nazik. Skills that we acquire through everyday life help us to be more resilient as we seek this excellence in the world of Black oncology. I learned and coined a few words today. So the challenge that we have is to have a shift of mindset about, supporting our patients and also probably improving ourselves and mentoring others. I'm going to give a challenge today, and Kesha will approach each of you, and we are going to create, a sort of log of all women in oncology and create a platform where we can be able to approach each other online on collaborations. If Chemutai needs patients in Africa, and we have access to Aga Khan Hospital, we have access to Kenyatta National Hospital, and wherever we can be able to create a cohort of research patients and give her probably access through the platforms that we use, for clinical research and creating access, because sometimes this is the problem. And in the same light, we approach, create platforms where we can send mentees to some of the areas where we have the privilege of being trained, of being exposed to research, and probably what Professor has called privilege this evening. So I'm going to take a last statement from each of you. And because our theme was basically on mentorship, I want each one of us to give a piece of advice to every woman in oncology about how she should carry forward her career. Just one line that was, may have played a role in your own career, and probably somebody taught you as you went along, and probably something you can hand over to somebody else. Thank you. We can start with you, Anne.
Thank you. I was just trying to think of something, but for me, I think the mentorship that made the most difference for me was the very first hematologist I encountered, Dr. Aino, who was able to bridge that mystery of hematology in the textbooks with a clinical scenario. So if we can be a bridge for our mentees, show them the reality, show them the working, guide them, hold their hand, and build them from a place of basics to a place of competence and a place of autonomy. I think that is what I would say for our fellow mentees. I wanted to just also bring in that Dr. Varna called women meticulous, autonomous, and socially confident. So in the rooms where we feel I can't really say it because these men are so loud, please just remember that mantra. You can do it and you have it in you. Yeah.
It's a super mantra. Thank you. So, Professor Nazik, one closing remark and advice.
Well, I say to all the women in oncology, I celebrate you, I honor you, and I value you. And I think just looking at the global picture of us as women of African descent, you are privileged to be in a position to influence the outcomes for millions of women who are your sisters, who are your grandmothers, who are your friends. And we do that through solidarity and through amplifying our voices together to support each other and maintain that level of excellence. And I want you to go into the world and conquer it.
Thank you, Professor. Chemutai, any closing remark, especially for the young people who today will look up to you and probably try to reach out? What would be your closing remark?
Thank you. I would say keeping the long view, which is another way of saying being persistent. I say fail forward. The paper will get rejected, the grant will not get funded, but nothing is ever wasted. I remind myself that all the time. Where I am in my career is 20 years of hard work. The grants I write today are much better than what my first grant 20 years ago, but it's persistence, it's failing forward, it's keeping the long view that somebody says that we overestimate what we can do in 6 months or a year, but underestimate what we can do in 10, 15. So, and all of us really have power within the sphere of influence, whether it's with the patient that you're seeing, improving the health system of the hospital. Ultimately, it'll impact, people you care about and your legacy. So, keeping the long view, nothing is ever wasted, and fail forward always.
Thank you. Thank you. Wonderful. Fail forward. The bigger picture. Excellent words. Professor Vanna, what would be your closing remarks about being meticulous and autonomous?
I would say that as a woman, we face so many challenges, both as single, married, divorced, whatever. We actually face a lot of challenges as women. So to additionally be an oncologist, either a nurse, physician, therapist, whichever field in oncology in which you are in, it's a brave decision, a lot of work, and that makes you a superstar. Remember you to be the light at the end of somebody's tunnel so we can move oncology forward in Africa. Thank you.
Excellent. The light in somebody's tunnel. So thank you very much. It has been very different, very insightful. And I think we have encouraged very many of our over 300 people who logged in to listen to this talk. We usually get around 600, Professor, but I think the other 300 are men. I hope the 350 were women this evening. And for sure, I'll keep my promise that I'll approach each of you so that we can create a log of all great women in oncology, young and old, wise and failing forward to keep this bigger vision that we've created today. What I've learned is your knowledge and skill must be unquestionable to fail forward. So thank you very much and have a great evening to all these great ladies. Good evening and bye.
Thank you. Thank you. That's good.